This leadership center has been doing um, projects all around the country focusing on this population, rightly so, because it has been neglected for many, many years. And they have been looking at this from the macro level um, in helping change a lot of policies nationwide. And then they've been doing these projects in each state. Pennsylvania had one a few years ago where we're focusing on changing the culture here and looking at what can be done in each individual state for helping people with behavioral health and substance abuse to quit. So I'm just going to take a very, very few minutes. As you know, we don't have a lot of time on these sessions to talk about this on a very individualized level. So the first takeaway, or the big takeaway here, is that people with behavioral health and substance abuse issues can quit smoking, and they should quit smoking. There are lots of good reasons for it. Now, if you look here, you can see that even though the rates have dropped relative to the overall smoking rates, it's still way higher than the general population. So if you go to the next slide, you can see, oops, yeah. You can see that in some diagnoses, there's huge amounts, especially schizophrenia. I worked in community mental health. I worked in a state hospital and did some individual stuff years and years ago. And I can tell you that almost every single schizophrenic I ever encountered smoked. And if they didn't smoke before they got in the hospital, then they did after they left. So these are, it's still a big issue. I know this is some old data, but the numbers are changing a bit, but they still haven't changed much. And you can see that if you have more than one mental health diagnosis, the rates go up the more problems you have. The same thing is with substance abuse. So if you go to the next slide, almost well over half to almost everybody in addiction treatment settings use tobacco. I am aware of 2 or 3 treatment centers in my neighborhood, and I can tell you that when they're on breaks outside, I would say almost everybody's smoking. The interesting thing here, and the important takeaway here, is that smoking, tobacco use, causes more deaths than the drugs or alcohol that the people are abusing. Same thing with schizophrenics. If you look at schizophrenics, the leading cause of death is lung cancer. So their smoking is negatively affecting them from a health perspective, definitely. And interestingly enough, there is still, while we have made great strides with behavioral health, there's still a long way to go with substance abuse facilities offering tobacco cessation services and, in fact, going smoke-free. I have a good friend who works in one in a suburb of Pittsburgh, and she's been fighting with them for years to try to get them to go smoke-free, and the management absolutely will not do that. And we'll talk about a couple of those reasons in a moment. Let me go to the next slide. So there's still a huge problem. There's still a lot going on. So the question is why? Well, there's multiple issues across the board here. There are many, many myths about smoking in these populations. Number one is that it helps them deal with their issues. Absolutely no evidence to that effect. If I quit, I'll get worse or relapse. In fact, the exact opposite is true. There's a huge amount of data now to show that if you quit, you're more likely to stay healthy from the mental health perspective, but you're also more likely to stay off of whatever else you were abusing. I love this one, and I've actually heard this from many, many people, people, especially with substance abuse. Well, you have to be addicted to something. And so smoking causes the fewest immediate problems, so I might as well be addicted to that. I don't know where that comes from. I never quite understood that. But you may encounter that. Again, no, you don't. You don't have to be addicted to anything. The vast majority of the population isn't. So, debase or abuse people of that belief if they say something like that. From a societal perspective, there's this belief that people with these issues can't quit and they don't want to quit. The reality is they can, and we'll talk about the special issues there. And they do want to quit. And again, if you look at the data, they want to quit at the exact same rates as people who don't have behavioral health or substance abuse issues. Now, from a cultural perspective, within the communities that deal with these individuals, and I have to say, I have to admit, I was guilty of this 45 years ago, so it's been a long time, but we used smoking as a behavioral management tool within the mental health community. So inside the hospitals, outside in day hospitals, that kind of stuff, we would bribe people with cigarettes to get them to do things, to take their medication, to go to group, to come and have an individual session. So it became a very, very powerful behavioral management tool. Fortunately, that has stopped, I think, almost everywhere. At least I hope so. And we never felt that it was a priority back then. You know, it was like, well, we have to take care of all these other issues. They're worse because they're interrupting and disrupting their ability to live their daily lives. So we never made it a priority. And on top of all of that, and this is still an issue, is that many staff smoke. So because of that, they are reluctant to bring it up because that means they have to address their own issues. And they don't want to. So if I have found this to be a big problem in many, many areas. Again, all of this is changing slowly but surely, but I wanted you to be aware historically of what many of these issues are should they come up for you. So the reality here, sorry, my phone's ringing. Hold on one second. I'm sorry, I get all these stupid robocalls all afternoon. Anyways, the reality is that if this, in this Cochrane report here that we see, this is a meta-analysis of a lot of the data that exists right now. So if someone quits, we see that it leads to decreased stress, anxiety, and depression. Cessation leads to increased mood and quality of life. So there are very positive aspects for individuals in these situations or with these diagnoses to quit. Individuals with drug and alcohol abuse diagnoses actually have less relapses rather than more. And interestingly enough, integrating cessation treatment into the alcohol and drug treatment leads to a 25% increase in long-term abstinence rates. Huge increases in the amount of people staying abstinent when they quit smoking. Why is that? Just very briefly, I think this is the issue. People who abuse drugs are looking for something outside of themselves to help them deal with internal problems. And if they give up the alcohol or the drugs or whatever, that's fantastic. But if they're still smoking, they're still psychologically looking for something outside of themselves to help with internal problems. So when you give up all of that, that then leads you, I think, to be more likely to help to look internally to solve these internal problems, which is where you really have to do the work. Okay, the next slide. So what can you do? What everybody on this call, what can we do here? Make your facilities tobacco free if they are already not. I know most behavioral health facilities are now tobacco free, but just like I told you, my friend's place of work isn't, so they're still out there. I want to tell you folks that every state hospital in the state of Pennsylvania went smoke free at the beginning of the year as a result of the project we did with the Smoking Cessation Leadership Center. If state hospitals in Pennsylvania can go smoke free, anybody can go smoke free. That is, I never ever imagined in my lifetime that would happen. And interestingly enough, one of the myths around that, and we've talked about this in the past, is that there's going to be like rioting or people aren't going to go to these places anymore. That doesn't happen. I have friends in substance abuse programs, a long-term sober people in AA and NA, and they really are working toward helping all of those programs go smoke-free too. You need to integrate treatment into behavioral health care. And the issue here is not if you should do it, but when. And we'll talk about that in a sec. And as I said, the data shows that people in both of these diagnoses want to quit and they can quit. So next slide, please. So what do we do with this population? How do we help them quit? Well, the treatment for these populations is similar to any other program. However, there's some caveats here. So number one, treatment may take a lot longer just because of all the other issues that are going on. Many of these people's lives are in disarray. So just be prepared to extend this as much as it needs to be extended in terms of the behavioral treatment. In terms of the medication, you remember way back to when we had to talk about that, medication can be, all these meds can be used as long as they need to be used. There's no data at all to show that long-term use is any kind of problem, and you may need to use 2 or 3 medications together. I found when I have worked with this population, especially schizophrenics, that their cognitive level might be lower than the general public. So you may have to adjust some of the words, some of the things that you're saying with the when you're talking to them. And you have to be, in some cases, more directive. Normally, I would ask people, what would you do instead of smoke in this particular situation when I'm talking about making behavior change? But in many cases, many of these people really don't have any idea what else to do. So we may just have to tell them. And you may have to deal with the fact that there just are more relapses here. So you need to look at that as part of the process and focus on not the fact that they relapsed, but helping them learn from the relapse so that you are helping them stay quit long term. And I'd like Linda to talk about this just for a minute after I'm done. I think almost every state quit line now has specifically trained their counselors to deal with these populations. So don't be hesitant to refer these populations to the quit lines. And also in the Cessation Center, the Smoking Cessation Leadership Center has some trainings on this. Peer-to-peer counseling appears to be very effective in this population. They're using more and more peers in all forms of treatment here, and it looks like they can be a very good support for helping people quit smoking. Now, I just want to very briefly remind you that, and we talked about this way back at the beginning, the hydrocarbons in cigarette smoke induce a pathway in the liver that causes patients who smoke to metabolize medications much more quickly than they normally would, and if they didn't smoke. Many of these medications are psychiatric medications. So what happens if they do not reduce the dose of the medication, that can lead to side effects. And what happens is the patient then thinks they are having all these really weird withdrawal symptoms when in fact it's too much medication. So the bottom line here is that anybody that you're working with who's on any kind of psychiatric medications, you really want to closely monitor their dosing over the first few weeks as their metabolism shifts. And in most cases, you want to lower the dose of the medication. Psychiatrists should be aware of this, so I just want you to know that this is something you should be referring them to their psychiatrist for. Okay, next slide. All right, that's it in a nutshell. If you have any questions, I think we have a few minutes here. But again, bottom line, they want to quit, they can quit. You just need to make a few adjustments into the programs that you are presenting to them. Thank you.
Great, thanks so much, Frank. That was a great reminders and an overview and some really important tips to remember when we're working with patients with behavioral health conditions. Does anybody have any questions?
Can't tell if there's anyone in the chat or not.
Yeah, Linda, do you want to talk a little bit about the quit lines and the their training and around working with patients with behavioral health conditions?
Sure, happy to do that, Laura. First of all, let me just mention that a lot of what Frank says are things that we do incorporate into Quitline service as well. About 45% of all callers to Quitline who get service report that they have a diagnosed mental health or substance abuse problem. So it's nearly half of callers are folks who need some level of protocol adjustment for behavioral health and substance abuse. Just about all of the quit lines have trained their counselors to be more welcoming and to have a sense of how to better work and how to better provide services to people with behavioral health and mental health problems. At Optum and National Jewish, they actually are pilot testing some new protocols where the protocol has been tailored for people with behavioral health conditions who want that kind of a program. The tailoring involves more frequent and just more counseling calls than regular population. And it also involves a longer duration of medications. I think everybody knows that most quit lines aren't able to provide full course of medications to most callers, but they do, many of them do, to those with behavioral health conditions. And the protocol also allows the quit line, with the permission of the caller, to contact that person's primary care physician, just to let that person, that primary care person, know that this person is trying to quit, that it may require an adjustment of their behavioral health medications. As Frank mentioned, when people start coming off nicotine, they don't need as much medication for their behavioral health condition usually. And so it creates a partnership between the quit line and the behavioral health primary care physician.
Cool. That's great. Thanks, Linda. That's cool to hear about and super important. Any other questions on this topic? Anybody? I was curious for our health centers. Are you all smoke free, or are you running into barriers becoming smoke free, or are there things that I don't know are interesting to share on that topic? I don't know if any of the health centers have any thoughts to talk about that.
Well, we're pretty small in Curry, but we're smoke free as part of the Department of Public Health. So that's been in place at least for 5 years that I've been here.
Awesome. Thanks, Angela.
Sure.
And it looks like Central Florida Healthcare is smoke-free, and Lancaster Health Center is smoke-free also. Yeah, that's great. It's cool. It's super interesting. I mean, I know the statistics and the data around the behavioral health specific centers and health systems out there, and this like curve of more behavioral health centers becoming smoke-free, but then some of those barriers and challenges, I find that super interesting and such an important sort of institutional policy lever that we can really make a difference and influence. So that's cool to hear about the health centers.
I think in many cases, the problem is that the person who runs the organization is a smoker and they don't want to deal with it. I've run into that many times. It's either the president or the manager, the director, whatever the top person is, smokes, and they just simply refuse to discuss it.